Good morning, good afternoon, good evening, everyone. Thank you for joining us for another series of our webinars organized by the Institute for Primary Healthcare, this time in collaboration with Last Mile Health. It's my pleasure to welcome you today to our webinar on blended financing for primary healthcare. It's a topic that sits at the very heart of health system transformation, sustainability, as well as equity. PHC is universally recognized as the most effective pathway to achieving universal health coverage, health security, and overall for the betterment of the population's health outcome. But unfortunately, despite its central role, PHC continues uh, to face a persistent and well-documented financing gap, and public budgets alone are often not sufficient, and external financing is usually constrained, and traditional financing models do not always align with the long-term goal or the system strengthening nature of primary healthcare investments. This is where blended financing becomes both relevant and necessary, which again brings us back to our discussion, which I believe is timely and important. And this webinar basically aims to move beyond the theory and explore practical models, real world experiences from very knowledgeable people, and hopefully policy considerations for applying blended financing to support primary healthcare optimization and envisioning. It's my pleasure to introduce to you our moderator who will guide us through this particular webinar. His name is Abraham. Abraham has been a close partner for the Institute. He is the country director for Last Mile Health here in Ethiopia, leading efforts to strengthen community health systems and expand access to quality primary health care. With extensive experience in developing innovative programs, policy implementation, and workforce development, he has been instrumental in scaling blended learning programs, AI-driven health solutions, and capacity building initiatives for health extension workers. Abraham brings a rich international perspective to his work, having contributed to public health initiatives across multiple countries, including Lesotho, Jamaica, and Rwanda. And in these contexts, he tackled a range of issues from HIV/AIDS and maternal health to health systems reform and digital health innovations. Previously, he worked with government agencies, international NGOs, and donor-funded projects focusing on health system strengthening, service delivery optimization, and financial sustainability. He is passionate about health equity and digital innovations, and he's committed to leveraging technology and evidence-based strategies to improve frontline healthcare services. He holds a background in public health and is a strong advocate for local leadership and global health initiatives. And it's with a huge honor that I hand over this session to Abraham. To you, Abraham. Thank you.
Um, Thank you very much, Dr. Abinet. This is really an exciting session with very distinguished panelists. We are going to uncover the topic of blended finance. Most of you in the webinar might have heard of blended finance, but might be curious about how it works. Some of you might have that experience. We will try to explore key topics. What are the instruments in blended finance? How does it work? Considering some of the funding challenges our sector is experiencing, how do we use blended finance as an instrument for expanding primary health care? We have really experienced speakers today. Very honored to introduce Nabil Kello, who is the founding partner for FC Africa, a social enterprise that designs and implements economic growth projects across Africa. Nabil work is centered on growth of business, creation of jobs, improving access to finance and investments. FC Africa was founded in 2006. Today, FC Africa works across 18 offices, making inroads for African organizations to lead large-scale projects by bringing both capacity and context for business-minded, innovative, and sustainable solutions. Nabil previously studied and worked in the UK with focus on consulting investments, then returned to Africa initiated Addis Ababa, initially in Addis Ababa and now in Nairobi, to support the continent's development process. And he is also the founding member for the first independent investment bank, which has been established in Ethiopia as well. It gives me great pleasure to hand it over to Nabil for some exciting experiences and examples on blended finance. Over to you, Nabil.
Thank you, Abraham. Much appreciated. I am going to try to share my screen. Please tell me if this works. It worked a minute ago. Let's try. Now, do you see my slides?
Yes.
Okay, I'll just close this. Okay, great. Where did it go? Great. Can I check you see it again?
Yes, we see it, Nabil.
All right.
Please go ahead.
Good. We'll stay on this screen. All right. Well, good afternoon, and to some people, I think good morning. So I'm Nabil. I'm the founder of FC Africa. We have been working in blended finance across development, private sector, and the financial sector for the last 20 years, nearly. And I'm going to share some experiences, and I'm going to talk a little bit about what do we mean by blended finance and how does it apply. As Abraham said, I started out in the financial sector in the earlier parts of my career, and I'm now back in the financial sector. And I think the first thing, we have to acknowledge is the power of this the private sector and the financial sector. If we just take the country I'm sitting in today, Ethiopia, we have an economy of 160 or so billion dollars. We have a financial system of about just banking assets alone, $50 billion. And then when we look at sort of ODA, ODI commitments and disbursements on an annual basis, it's a few billion dollars. Government budget, 10 billion, a little bit more this year, I think. So we're talking about a much bigger pool of capital. So the power is there, but the requirements of that capital, have not funded primary healthcare, have not funded other social services. They have different requirements, but it doesn't mean that they cannot. It just means that they need to be unlocked, and I think that's what blended finance really is all about. So I'll go into what it is and what it's not, why it's needed, our experiences in applying blended finance, some key lessons, and some just illustrative applications in the health sector. So, as I said, blended finance is about tapping into larger pools of finance. We've seen the need for government finance to provide primary health care, the Abuja Declaration, other commitments to ramp up resource from the Ministry of Finance. But there's always limitations to that. Whether we get to 15% or 20% or 10%, the reality is blended finance can amplify that. And the key principle is, how do we ensure that an investor is getting what they need, but also at the same time enhancing the system. An investor will look at feasibility. They will look at affordability in a different way, maybe, than typically a public sector or other nonprofits look at that. So that kind of commercial discipline is also another benefit. But essentially, it's about two things. There's two reasons why an investor will not invest in an investment. One, the biggest one is typically risk. We often think investors need a return. The return might be there with a given level of subsidy in the primary healthcare sector, but the risk is another thing that needs to be considered. And so when we look at blended finance, we're not just blending, $1 here with $3 there. Sometimes it could be, $0 from the public fund and all privately funded, but the risk is mitigated and the risk is managed. And we'll talk a little bit about that in different ways. But there are different ways to mobilize private investment. I think traditionally I've been working in private sector development for a very long time now. And traditionally, when we want to get businesses and investors to invest in things, we give them a grant. And that is one way of moving them into a different space. But the success of that on its own has not been very high. And the one thing I want to say about blended finance is, we can look at grants, we can look at concessional debt, and we'll talk about that in a minute. We can look at offtake agreements saying we will provide payment for the output of your factory or of your business. We will guarantee you revenues, right? So that's a different kind of a guarantee. There could be a financial guarantee for a loan. There could be all of these different tools, but the reality is often most of them don't work on their own. You need to tackle a couple of points of the investment life cycle in order to de-risk something. So I'll just talk a little bit about why it's needed. I think I've mentioned, the ODA, just take Ethiopia, was $4 billion, okay? 1% of GDP. The private sector is a much bigger sector, but have very, very specific requirements. And one aspect of that is, and critically is sustainability. A lot of the time, a business person, a bank, will be able to tell you whether this market is sustainable in a way that we often, or in the public sector, don't analyze in that same way. So again, that's another sort of impact of bringing in the private sector from the beginning, bringing in the financial sector from the beginning to blend finance with them, and to also recognize that they are the majority shareholder in these facilities and in these services. And they're going to have to call the shots. We are just here to de-risk or provide a little bit of upfront capital or whatever it is. But essentially, it's about also shifting the emphasis on who is owning the service delivery. How it works in practice, I think we talk about different market failures that prevent capital from flowing into sectors that provide impact, right? A bank today does not care whether a loan that it gives is going to create 1 job or 100 jobs, or it's going to improve the lives of or the health of people, or not improve the health of people. That's just the regulatory framework. And we'll talk about regulation in a minute, because I think one of the things we have to also appreciate is that what we need to do in blended finance is not so much pilots, and it's not so much proofs of concepts. Blended finance is not this big top-down thing that happens, from far away and just lands on a community. Blended finance has to be community-owned, has to finance or to qualify for facilities that are negotiated at a national framework level. So a couple of points, public and donor capital is used first, but it cannot be the majority of the investment. I talked about the risk sharing, which is very important. We also have to be careful not to see private capital as replacing public capital, but really thinking about joint ventures and joint financing instruments. And it doesn't, again, mean $1 here and $1 here. It could just mean that the first risk is taken maybe by the private investor, or the last risk is taken by the private investor. And so it's about managing risk. The instruments that we use, typically guarantees, are very, very powerful, and other risk-sharing facilities. You could guarantee someone's loan, but you could also sort of guarantee someone's revenue, right? The public sector is often a big buyer of services, or donors can be, buyers of services, or of products, or of medicines, and so on. So we can also look at guaranteeing revenues. First loss or subordinated capital means, if there's a loan and part of that loan is not repaid, the first part of that loss could be guaranteed. So you're not guaranteeing 100% of the loan. Maybe you're just guaranteeing the first 10% of the portfolio of loans. Technical assistance is very, very important to ensure quality delivery. and particularly results-based and outcome-linked payments. So we've heard about development impact bonds, social impact bonds, where a loan would be given in order by a development finance institution or a multilateral development bank, but that loan repayment would fall on the community, the county, the whatever, the district, the government. But based on results, if the results are higher, you could see a donor potentially then covering those payments based on good results measurement and saying, if you deliver certain health outcomes, we will then cover those payments. So you're setting the incentives, and I think blended finance is all about trying to ensure that the incentives of the investor are aligned with the incentives at the national level in terms of health outcomes. So there's a number of different ways to do this. I'm gonna just talk a little bit about what we do in this space very briefly. We design blended finance structures between our advisory organization, First Consult, our investment bank, First Addis Investment Bank, that structures the finance solutions, brings investors directly into solutions, and then the FC Development, which does the program implementation side of things. I won't go into too much more on that. I'll give an example of a blended finance instrument that we used in Ethiopia to mobilize banks to lend to small, medium enterprises. So we managed to bring about $50 million of funding from a foundation, in this case, MasterCard Foundation. The banks were initially committing $30 million to match the specific lending portfolio. Some of this was grants, program management, other things. And now in its sort of fourth year, what's interesting is that the bank is continuing to lend, and we've now gotten over $60 million for that initial $50 million. Within a couple of years, that'll reach $100 million of private finance, partly because of the initial guarantee, partly because of the technical assistance, partly because of the regulatory framework in the financial sector that is showing this as a sort of a viable business for banks, and now getting money to go to small, medium enterprises. I'll pick another example, the wind power plant in the north of Ethiopia in Tigray region called Ashagoda, where we facilitated 25% of the loan, which was a $200 million loan. 25% of the loan the interest rate was reduced basically by 4% via a development grant. And that enabled another 75% of the loan to be purely commercial, coming from a French commercial bank. And so, again, I'm just showing you different examples and different ways in which you can de-risk or you can enable basically other money to come in. And so basically what you're getting is much more bang for your buck. But as I said, every single project has a different requirement. And so there are so many different ways to do this. A couple of sort of key lessons learned. There's no one size fits all. Every project has a different risk profile. So some will need more private finance, some will need less, some will need more risk sharing, some may not need so much risk sharing. So design is really critical, but putting the right structure in place to understand the private sector and the financial sector's incentives and making sure that they're participating very early on and really leading, in a way, the design of the project to understand, the consumers of these primary healthcare services and their needs and their affordability, and to say, what do we need now to invest in this? Getting that early on is very, very critical, and balancing the public and the private benefits. So it's all about aligning incentives, really, and understanding incentives. And I would say the key to working in blended finance is to understand not just the interests of the public sector and the private sector, which is very clear, which is, health outcomes and profits, but to understand the incentives, which are very different, and to understand how to align those. And that requires facilitation. So, as I said, there's no one size fits all. You could have more risk sharing, less risk sharing, higher amounts of private capital, lower amounts of private capital. And I think it's really important for us to create frameworks to support, as I said, local level, to be able to design and manage those projects. I think we're going to share the slides, so I'm not going to go into too much detail. I am giving you an example of I'm going to give you an example of something we did in the garment sector. So coming out of health, because we work across so many different sectors, where an industrial park in Ethiopia was invested in by the government, $1 billion of investments in industrial parks, based on an agreement with a buyer of garments that was able to then attract, just because they were the buyer, a number of investors to build factories. Right. So we could see this happening, for example, in medicine production, manufacturing, in MMS manufacturing, and other things like that, where we can pull together the government, the private sector, and essentially the purchaser, whoever is doing mass purchasing of these sorts of products, where the investment could actually be very small in the public sector, and it could be entirely private sector, only using essentially guaranteed purchasing power. So that's one way to structure it. India has very interesting example around the Utkrisht impact bond, where we saw, and what was really interesting was not just how much capital was able to be mobilized by the financial sector, but how results, because of the alignment of incentives, how results and outcomes improved significantly. I think there's a lot of talk at the moment as well around not just development impact bonds, as I said earlier, where you provide the results-based repayment of the bond to the country, but there's also, the sort of a new line of discussion, particularly more in the climate space, that is now coming into the health space around bond swaps. So taking existing debt and saying, we will cover the payments of your existing debt as a country based on the outcomes you're achieving in the health sector. And there are foundations and other donors that can facilitate that kind of a conversation in order to take essentially existing money and future payments and to achieve better health outcomes, which would also link back to the Abuja Declaration around investment. So setting an incentive for the government to increase its share of spending for health based on not just a commitment, but based on incentives and incentivizing that. I have one more example, the Mama emergency transport in Tanzania, and this was specifically around obstetric care. I think there was, this is a really good example. I think people could look into this more to see, really how the reduction in maternal deaths was integrated into the financing structure. Often we think of service delivery and service performance as something that requires, investments in human capital and so on. This is a good example of how you set incentives for those things to just happen, for people to invest in systems, invest in people, and not necessarily from a programmatic perspective saying, we think you need to invest in this, we're going to fund it, but more setting the incentives. And I think this was a great example of that. I'll stop there. Thank you very much. I can take any questions later, I believe.
Thank you very much, Nabil. This is quite fascinating, especially for those of us in the health sector. I believe this blended finance idea most often is being applied in rural infrastructure projects, climate change, not really health. And thank you for highlighting some of the examples in health. The M-Mama in Tanzania, I know the Ministry of Health in Ethiopia is considering M-Mama. I know Ministry of Health in Malawi has already started implementation. So it has so much promise and potential. And some of the data points you mentioned, like official development assistance in Ethiopia is 1.4 billion in 2024. And the biggest question is, how do we use that 1.4 billion to attract much more resources from the private sector? And how do we channel those resources in rural areas where primary healthcare happens? So a lot of fascinating points and so much to learn, especially for those of us in the health sector from the overall development sector. So thank you, Nabil. Those of you who have joined our webinar, thank you again for joining. Nabil just delivered a very fascinating presentation on blended financing. Keep your questions coming. On the chat, we'll now move to Tamasken Tasfu. Tamasken Tasfu is another distinguished speaker for this panel. He currently serves as a director for strategy and innovation in the International Primary Healthcare Institute in Ethiopia. In his role, he leads the institute's efforts in anchoring priority health system reforms and innovations, as well as coordinating multi-country technical support across Africa and beyond. Prior to this, Tamasken has been engaged in shaping health policies, strategies, and advancing equitable access to primary health care with a focus on innovation, system resilience, and cross-country learning. He has played a key role in fostering partnerships with governments, development partners, global health institutions, strengthening health systems, and promoting evidence-based reforms. On top of that, I've personally collaborated with Tamasken on a lot of health financing projects. He has made a significant effort in costing of the National Primary Healthcare Plan, as well as several health financing projects. So has a in-depth knowledge in health finance. So Tamasken will give another presentation on health financing from a health perspective. Over to you, Tamasken.
Thank you, Abraham, for the very generous introduction. So I'll make a few minutes of presentation that I hope would complement to the wonderful presentation that Nabil did, with a more deep dive into the current context around innovative financing for health and in particular for primary health care, with some of the opportunities and the way forward and so on. So particularly taking the case of Ethiopia, where primary healthcare is the sort of backbone of the health system, where around 90% of the essential health services are delivered, or in layman terms, this is where mothers go to a health facility to deliver, get education about preventive cares, nutrition, and such. And where most of the preventable diseases are tackled. So the majority of the investments as well as the efforts so far in our health system has been spent around this area. So the issue is, okay, so we've learned that this is an important component of the health system, but the question is, how do you sustain the finance? So the next few slides show a little bit of the financing landscape. This I talked a little bit with that political commitment on the primary healthcare and the community health program, having resulted in so many of the health gains that the country has achieved. With those health gains, particularly morbidity and mortality, child and mother mortality significantly dropping, even though that decline has slowed a little bit, particularly post SDG period, which could potentially be attributed to some of the financing problems that we are trying to address. But this is basically aims to illustrate the sort of role and importance primary healthcare has in the system. And I believe this also is the case for a lot of low and middle income countries. So next slide is meant to illustrate the current financing landscape on primary healthcare, where a significant portion of that spending on PHC is coming from out of pocket, around a third from donors, and the remaining from government, and a small percentage from others like private sector. So even though in nominal terms, this overall total spending is increasing, per capita spending is being challenged, especially in consideration of some of the commitments that the country has entered into. And with some of the socio-economic demographics and cost of delivering health increasing, this is something that's also becoming a challenge. Taking ODA shift or bringing ODA shift into the picture, the problem becomes even critical. So next slide, please. Okay, so we've seen the importance, we've seen the financing, and okay, so how do so what to do about it, or what are the mechanisms for us to sustainably finance it, and this is where the blended financing comes as one of the innovative financing mechanisms. Looking into the different scenarios, backgrounds with the ODA shift and all, we need to come up with innovative ways to unlock additional resources from different sectors, particularly the private sector with government and donor resources as a way to catalyze and provide guarantee. So I won't go in deep on the key or the different models since Nabil has explained them in great detail, but just a certain sort of flagship numbers and stats here. There's done our research, which is globally, where particularly for blended financing to health, somewhere around 84 investments have been reported or at least documented with a combined total value mobilized of around 70 million. And this around 2.5 billion of that capital ready for deployment. And overall, what also makes blended financing useful, in addition to unlocking additional or tapping into additional resources, is that the return on the investment is for every dollar invested on health with a $3.3 investment reported in most of the cases. We're not talking about blended financing out of the blue, meaning like everything that happens in the health sector, one way or another needs to align with the existing initiatives, policies, and strategies. So here, the objective is to illustrate some of those supportive policies and strategies, particularly the National Health Financing Strategy, the 10-year National Health Strategy of Ethiopia, emphasizing on the importance of expanding risk pool and lowering out-of-pocket, as well as aligning those different sources of funding with some of those strategic purchasing reforms happening, particularly results-based financing or performance-based financing, currently increasingly expanded into a significant part of the country, which once used to be a pilot in a few areas, which is one mechanism of the blended financing, not the only one. Complementary initiatives such as insurance, also significantly expanding nowadays with preparation to start the social health insurance as well. And of course, some of the so we've seen that private and maybe semi-private or developmental banks would have significant role to play and operationalizing blended financing. So some of the G2G or the bilateral discussions that's happening with the WHO and the European Investment Bank are also promising that we can tap into sustainable financing primary healthcare moving forward. Next slide. So for this particular session, and this is another illustration of health-focused case story on some of the comparable countries in Africa. How did it work? Was it successful? So what's the key take? And again, we would share those slides for the participants here that can be referenced, but one case story in Cameroon, and this is a practical example that was initiated and led by the Cameroon government. And this happened in 2018, where they were able to unlock certain resources to support kangaroo mother's care, which they've seen a tremendous health outcome through investments made in this regard. So the lessons documented through this initiative is implementing or putting in place clear matrices, credible verifications, as well as government ownership throughout this process. Another case story, particularly for Kenya, where they were also able to, which is on the, they were able to unlock more than 10 million USD. And I think with the projected potential of unlocking another 6 or 7 million developmental bond, particularly pegged for adolescents sexual and reproductive health, is also a good example that can practically be benchmark to factor into some of the ongoing initiatives that we're taking on. Similarly, this is not a specific country experience, but this is talks about the Global Health Investment Fund that is being that they were able to mobilize around 108 million from different donors and commercial investors. That is market financing some of the manufacturing supply chain innovations around the world, and this has proven that, and some of the earlier results have proven that those could actually serve as alternative, not just alternative, but sustainable ways of financing some of the priority health initiatives in countries, including primary health. Next slide. So the remaining few slides takes the concept a bit grounded, which is okay. So and part of the reason why this discussion is timely, particularly for the Ethiopian health sector, is the country has been undergoing a number of reforms for the in general for the health sector, particularly for the primary health care, with the health extension optimization roadmap completing its first phase of implementation, and some of the health financing strategy and digital health, as well as HRH reform. What's unique and interesting is, and especially for some of those of you that have been following some of the change that's happening in the Ethiopian health sector, is that the ministry is undertaking a primary healthcare re-envisioning exercise, which our institute, the International Primary Healthcare Institute for Ethiopia, is technically supporting that, would create a timely and once in a decade opportunity to actually utilize the potential of blended financing, because that's one of the key areas that, with all the shifts happening, with COVID having disrupted a lot of things, with conflict regressing a lot of infrastructural and some of the key components of the health system a bit backwards, and of course with ODA fluctuation posing a significant threat to the financing portfolio of the system. This exercise aims to unlock innovative, sustainable financing mechanisms, among other things. This is not something that's happening in isolation. The country overall also undergoing a significant rural and urban economic and social development initiatives, to which financing is a key component. With everything that's being done, the bottom line is, how are we going to finance it? So conventional financing is one option, but as a sustainable, not a sustainable option. So carefully planned and mapped out sustainable blended financing option is something that this pitch envisioning exercise would take advantage of. There's one more slide on some of the key considerations on how blended financing could support the page set envisioning. This somehow relates with some of the conceptual key considerations that Nabil has outlined, but I'll just focus on a few of those, which is so the private sector are looking at the private sector investments or similar complementary investments with this blended financing is not meant to be to replace government or other sources of financing, particularly government financing, because I mean we're talking about a community-based, heavily government or donor-funded, at least historically, investment area, which for a lot of times have not been as lucrative, but recent developments in the sector, so in the country, such as some of the policy shifts, particularly in the agriculture sector, is also something that gives hope for implementing such well thought out, well designed, innovative approach in the health sector. And a second point here is also this is not an effort to prioritize primary health care. Rather, this is an effort to use existing government and partner resource to de-risk private sector investment, as well as unlocking additional resources to the health sector, in a way shifting the prime custodian role of the government into a more and from a policy to a financing a spectrum to a more sort of policy focused opportunity unlocking role, where a lot of the players and capabilities and resources from a lot of stakeholders can be utilized to fund this ambitious and perhaps an extensive endeavor that the country is trying to implement, and it is primary healthcare space. So I'll stop here, and of course happy to answer and look forward to the discussions and happy to answer any questions related to some of the contents in my presentation. Over to you.
Thank you very much, Tamasken, and that's a very interesting presentation and information you have given us, including, with a focus on Ethiopia, and I particularly like your slide about, Ethiopia being at this inflection point, considering some of the very important factors that you have mentioned. Maybe one question to both of you, Nabil and Tamasken, is, when you travel across Africa, be it in Ethiopia or in other African countries, it's very easy to see that capital is concentrated in few urban centers. Out of the 1 billion Africans, 700 million or more are living in rural and remote areas, what we call the last mile. So how do we shift that capital to rural areas? And how do we, is really blended finance the way? Is it really a game changer, or is it being overpromised? Because sometimes in development, one intervention or another is overpromised as a silver bullet, but then in reality, in terms of implementation, it stumbles. So do you believe it's a game changer? And does it have a risk of failing as well. So can you reflect on that? Over to you, Nabil, and then Tamaskin, please.
Okay, thank you, Abraham. It's a really good question. I think capital doesn't have an inherent need to be in an urban area, right? Money doesn't care where it goes. It has a need to manage risk and return. People sometimes have more of an inherent need to be in urban areas. And people who can attract capital, typically the capital goes to larger businesses, larger organizations that tend to find themselves based at least in urban areas, if not operationally in rural areas. So I think there's a need to think about how to ensure capital is getting into the last mile, into the furthest to reach areas. And I think it's about looking at the structure of the financial system. If a financial system in a certain country is overwhelmingly banks, I'll give the Ethiopia example because 97% of the money of the financial system in Ethiopia sits in banks, 3% in microfinance institutions. Then, of course, 3% of the money is going to be in microfinance, which typically is more rural than banks. They have a much bigger rural footprint, but much less of the money. So if you want to see more money going into rural areas, you want to see more money going to microfinance. By that extension, you would also want to see money going into savings and credit cooperatives, RUSACOs, and other types of rural financial instruments that organizations like IFAD and the World Bank and other people tend to work on. I think that's the first thing. The second thing is, we can set the incentives, right? So as I said, as a country, government here manages a budget of 10 billion, but then they're the regulator of a financial system of about 50 billion, right? So what's to say, we couldn't say to the banks, look, we will ease things up for you if, more of your portfolio is in rural areas, right? So you give the banks incentives to do more of that. It's tricky. It's not an easy thing to do. A long time ago, people said targeted lending and telling banks where to go and what to invest is not a good idea. But I think in the developing country context where we have, as you said, essentially financial systems that tend to fund shopping malls and telcos and the sort of organizations that didn't even need the domestic resources as much. I think there is a role for smartly incentivizing them to move into rural areas. Thank you.
Thank you, Nabil. Over to you, Tamaskin.
Thank you, Abraham. So I think so. Nabil has illustrated it very well. I can only add a few things, which is I think so. The success in the agricultural sector, so particularly in Ethiopia, can be adopted and ways that fits into the health context. So this is a developmental so a social sector which for a private sector with the prime motive being increasing the bottom line may not always be an attractive one. So the problem that we're trying to address is how can we unlock more resources from the private sector? So I think the answer there, at least a very simplistic answer there, is we need to make it as attractive as possible. So one way to make it attractive, where what the blended financing approach is proposing is, okay, let's unlock some opportunities, de-risk the investments, do this, do that, or maybe match some of those things so that it becomes attractive to the private sector. And I think so. The example that Nabil mentioned for microfinances. So there was state-owned banks such as commercial banks, for instance, up until recent times had the highest number of branch, and that was a policy sort of backed initiative to enhance access to finance. With health, I think not exactly the same, but a similar model can be adopted. And we know, at least for Ethiopian context, a lot of the approach, including the community health um, program, has been adopted from health. So similarly, some of that financial models or financial access models, investment models can be adopted here. The last one point that I want to mention is, so what is the alternative? So the reason we've been having developmental aid for and that much and for a very long period of time is because if the government is not able to provide an affordable primary healthcare services, then that needs to be balanced by an out-of-pocket, so which makes it unaffordable for the people to access. So to mitigate that, aid comes and government subsidizes a lot of those services. So with those, particularly the aid part, sort of dwindling, if we're not, and of course the fiscal space for the government spending sort of tightening, the only alternative is health becomes unaffordable because the people have to pay on their own. And I think, so the shorter version of what I'm trying to say is finding additional innovative ways to finance this with a parallel efforts to strengthen mechanisms to make health affordable, such as CBHI and SHI, at the same time, while finding this innovative mechanisms such as blended financing, finance supply side, supply aspect of the health services. It's not really an option otherwise, because the alternative is that we're not going to have those health outcomes, access, and affordable primary healthcare services at all. So it's an opportunity at the same time, and also like something that we don't have an option, but to go down that road.
Thank you, Nabil and Tamaskan. There's an interesting question in the chat about risk and who's carrying that risk. And I think both Nabil and you have mentioned de-risking and incentivizing the private sector by de-risking. So who carries the risk? And does the private sector carry any risk? And in the life of a blended learning, a blended finance project, what's the share of the risk and how does the risk profile change over time? Because this is a critical question, because if we are putting all the risk on development funding, are we not just recycling development funding in a different form and just giving it a fancy name called blended finance without really, transformation of how financing happens? And Nabil, can you take this? And then Tamas can also be good if you reflect on this.
Thanks. I think it's a really good question, and I was going to talk about that. I think the first thing we have to separate as we talk about blended finance is when we see public-based delivery of services and private-based delivery. And there's a couple of questions about PPPs and cost sharing and things like that. But I think it varies, right? So, and we need to separate the service provider, whoever is the frontline delivery of services and products, and the financier. And again, the risks are at different levels. So what I'll say is this: if you're a funder, if you're a foundation that is funding projects in the health space in Africa or anywhere for that matter, who do you want to hold those different risks, right? And I think the first thing you would want to say is I don't want to be the one holding the risk, especially the delivery risk. as a funder. And so part of, one way of looking at blended finance and what does it really mean? Is it this new word or is it something genuinely different? One way of looking at it differently is that it's shifting the role of the funder from financing inputs like, equipment and paying for clinics to be built, but towards funding outcomes and to saying, look, based on service delivery and health outcomes, that's where I'm putting my money. And that, for example, is a development impact bond. It precisely does that, right? The departure, I think, with blended finance, though, is also where we say, look, we're not necessarily the only funder. We're enabling another funder to come in. That funder just wants return. They have a lot of money, way more than us, but they just want to make sure that their risks are managed. So as I said, whether it's public delivery, whether it's private delivery, is sort of secondary. You do have to look at it differently because is the receiver of health services or products paying, or are they just paying taxes and it's coming out of that? So it's a sort of different financing model and a different revenue model. And that has to be structured, as I said earlier, in the design. But in reality, what you're really doing is just saying, look, put aside the risk of delivery on the front. I'm actually setting the incentives for the people who are delivering to be more aligned to my funding, right? So if I'm funding clinics, I'm not necessarily giving the assets and saying, now good luck, I hope you're going to do a great job. Do you want some technical assistance? It's actually saying, no, my funding is only going to be there if you deliver on the front line. And the person who's actually going to fund it up front, because I'm going to come in later based on the outcomes that happen later, the person who's going to come up front is another financial institution. Now, to make that financial institution now come in, so this is the funding risk we come to make the financial institution come in, we're going to say, well, look, is this project feasible? Is it viable? And I think one of the main challenges with healthcare in Africa, and we see this with health insurance and with other things, there's just a fundamental truth to the matter, which is the services that we need are not necessarily affordable by all the populations. And therefore, a certain amount of subsidy needs to come in. But how do we do that subsidy smartly without crowding out all that private capital that exists? Because our money is not enough as governments and as development funders. So how do we enable them to come in and how do we de-risk their investment? And then the people delivering on the ground, how do we make sure that they're still taking the risk for outcomes and we're not taking that away? So I hope that clears it up. It's really about, and this is what I meant when I said earlier, incentives. What are the incentives for everyone to get what they want that allows a lot more money to come in and outcomes to be, I would say, more assured? Thank you.
Thank you, Nabil. This is really interesting. I hope our participants are also finding it really interesting. Over to you, Tamaskan.
So I'll give a specific example, particularly from Ethiopia, which is around the performance-based financing, where facilities and frontline healthcare workers were incentivized based on some prorating rate for a specific agreed upon amount. So I know I know about that initiative, the pilots and the results to some extent. So I think the conclusion is in short, it has proven to be useful to incentivize or to pay for performance to facilitate and healthcare workers. So the question is, who pays for that? Who pays for the incentives? I think so. Looking into for this particular project, I believe some European donor, maybe World Banks or some implementation partner, has been paying for that pay for performance, and of course that's been scaled with probably some co-funding by regions and the federal government. I don't exactly know the exact numbers of that cost sharing, but since the idea of that project was sort of to prove that it works and to find ways of scaling it, the idea is the government would eventually find ways to fund to pay for performance because it has proven to be more effective in terms of quality access to healthcare services. But and a lot of, so including the cases that we have that I have tried to illustrate earlier in Kenya and Cameroon, and most of those settings to which Ethiopia also belong, that risk and the financial flexibility usually comes from developmental partners because governments do not have that flexibility to test out this kind of approach. Maybe because of the procedure, for instance, in Ethiopia, we have a very strict public financial management process. So it's projects such as this one, the performance-based financing, that gives confidence to the government to try and scale this with blended financing or with alternative similar financing to take on to the next level, which is scaled to other countries. So I guess the shorter version of what I'm trying to say is particularly for HUDs, particularly for less and medium income countries, to which Ethiopia is also one. The de-risking part, which is giving that confidence to the private sector to say, yes, your investment comes with a little bit of risk, but not too much risk, because if there is a loss, a huge loss, at least the upfront loss, we would take on that. So which means it's not risk-free, 0%. It shouldn't be, because in that case, it's not going to be rewarding. So, but that upfront and the riskier component of that investment would be taken on by the government as well as funds for this purpose. To your question on are we sort of finding a different name for reusing aid, for instance? If we are so, and I think we're making the best use out of funds. I mean, and instead of continuously creating dependency through sort of covering component of the health system, which by the time the fund ends, there's no one to cover it. I think this is the best use of developmental aid, in my view. So, yeah, that's what I feel.
Thank you, Tamaskan. Thank you, Nabil. Really good points, and how risk is spread across the different players. It's really a very innovative model, I think, which the health sector should explore. There's a question on the chats which says that what are the policy enablers for the blended financing to work? I'm going to maybe give it more of a realistic example. Um, the Ethiopian government recently announced the initiation of the Rural Corridor Project. Model rural households were built. I actually had the privilege of visiting those households. I was quite impressed. These are households with internal plumbing. These are, houses which are powered by solar panels. They have biogas powered cooking stoves. There's, a nutrition aspect to it. There's a healthy form of animal rearing, harvesting honey. It's quite transformational for primary healthcare and overall for rural life. So it got me thinking, who's going to finance this? And how do you get Dashan Bank Awash Bank or Commercial Bank of Ethiopia to finance something like this, or EcoBank or Standard Bank or any other African rural areas. What makes them say yes is the question, which is related with maybe what are also the policy enablers that the government can establish. Tamaskan, over to you, and then Nabil, please.
I think so. Some of the things, I mean, so this is a kind of thing that would require a major policy shift, to be honest. And so the good thing, so I mentioned the example of so Ethiopia following a strict public financial management system, which, for instance, in some of the projects to test out some financial mechanism rearrangements initiatives, it's not always easy. So this kind of unless you do it with a special permission with a special pilot site, because like it's a very sensitive asset within the public sector. So I think one, it requires a major policy shift to adopt such outside of the some of the mechanisms that the sector have been used to. So I'll give an example. So PPP is something that have been introduced at least formally into the Ethiopian public system. I don't know, maybe 8 years. So no formal PPP approach have existed before, at least at that scale. And this was one of the major shifts that have unlocked a lot of private sector resource, even though health was one of the late entrants into that. And with that, and I think so that's materializing into some of this health services, which is being tested in others. And I think that kind of commitment and shift, and because this is also something that probably needs to be cited at a manageable scale, because like you want to learn and then scale instead of opening up a system that have been closed aid and public financing dependent for a very long time, and to something that maybe the system doesn't have the capability or a mechanism to have full grasp and control on. So I would say a major policy and orientation shift. And of course, having that method. So look, health is a public good, right? But it doesn't mean that it's only the role of the government to continuously deliver on this. The role of the government is to make sure that that service is delivered. So always sort of finding alternatives, best alternatives, efficient alternatives, learning from tested approach from others and inside, something that I think the sector can absorb, and we have good financing strategies that can be practically translated into this one. With the re-envisioning exercise, among the different things that it's expected to bring about, one is, let's just take a step back, right? So the same point that I tried to mention, what do we need at the end of the day? We need healthy people who have access to quality and affordable care. So what are the alternatives for that? So what is the current ones? What have worked? What hasn't worked? And instead of trying to cling on to something that may not have been working, and therefore we just stick to it because I don't know, for whatever reason. So what we're trying to do with this re-envisioning exercise is, again, that looking into outside of the box and try to find those innovative mechanisms, which I believe the political leadership as well as the sector leadership is taking up on and is spearheading those kind of reforms. Yeah.
Thank you, Tamaskan. Nabil?
I think Tamaskan really covered it well, but I'll just add maybe one small point. I think there's from a policy perspective, and it links to the point about sort of finance getting to the rural areas. It would be, as I said, the role of this, if we want a big bank to come in and finance something in a local area, there needs to be a sort of an intermediary framework. And I think that would be the sort of the policy intervention that a federal government would need to do, or a central government would need to put in place, is to say, what is the framework that we're going to set up with, to some extent, the possibility of a sovereign guarantee, or of something that's sort of backed by the state, that would then enable at a local level counties or districts or regions to apply for funding under a national framework. And that would be one way of setting, again, the right incentives, but facilitating a blended finance, but not necessarily dropping it, but making more of like a bottom-up and top-down mechanism, whereby I think, and we've seen this in other things in the agricultural sector. We've seen in Ethiopia in the past, federal government budgets have been dispersed to regions as they get dispersed every year based on budget allocations. But sometimes there have been deductions from those budgets based on repayment of loans for fertilizer, for example, that are coming out of the cooperatives in a region, right? So that's, again, a sort of a performance-linked payment system. So why can't we have something in the health space that says, again, looking at performance, can we not have some sort of a link to budget allocations, on the upside and on the downside? So there are different ways, I think, that we can, and so I'm going to try and give more public sector examples here, because it's not only about the private sector. But I think there are different ways that we can enable money to reach the bottom. But I think what we've got to, not the bottom, the furthest out communities, but we've got to make sure that ownership absolutely stays at the most local level, because for those investments to perform, you need a sort of national level framework, but you need a local level of ownership. And those are the two key incentives that I would see. A policy framework would need to be put in place to make sure that that is upheld. Thank you.
Thank you, Nabil. There's one powerful question on the chat, which is saying that if there are issues in terms of quality of service, in terms of trustworthiness and credibility, working on the financing level alone, do we think is transformational? How will it translate into impact? So that's, I think, an important question worth answering. Maybe Tamaskan, you can reflect on that. Nabil, when Tamaskan was presenting, he assured us that blended financing is not privatization of rural health. But as you are attracting private capital into health and incentivizing it with de-risking, once the risky initial investments are done and there's more and more incentives, don't you think there's a risk of privatizing rural healthcare and thereby potentially making it unaffordable? Tamaskan, over to you for the first question, and Nabil, over to you for the last question.
I think, yeah, so all the presentations and then, of course, the discussions after, we're focused on, okay, so how do we get more money for financing primary health care as an alternative and sustainable way to finance the system? But yes, that big question, so is more money going to solve all the problems that we have with primary health care? So the short answer is no. because it's not the only parameter. It's just one of the biggest issues that we're trying to solve. So how do we make sure, even if we put in place those systems, mechanisms to source more money, de-risk things, invite private, semi-private capitals to the sector? I think I'll just mention one thing, and I will illustrate that with an example. And this is also both from the experience of the PBF, performance-based financing, both that happened here and also in other countries as well, which is, I think the way that you set up the system on so what results you want to fund, how are you going to measure, how are you going to ensure that check and balance is going to matter? Who's going to verify? How do you make sure that system is in place? Is a very critical thing, and I think one of the main reasons success in such initiatives actually owe to a strong design of the system, both from a sourcing as well as from a controlling mechanism. I'll give another example, which is which is on the community-based health insurance. So I've worked quite a bit on a community-based health insurance in Ethiopia, at least. One of the consistent issues that's being raised is separation of provider and purchaser, which is if a facility does not meet that standard, is not providing out quality, is there a mechanism for you not to pay them or deny them some contract? If there's none, then they don't have an incentive to improve, to continue providing that service, to, in our case, maybe get more a return for the money that's being invested. So I think starting small, testing out your approach, your system, your control mechanism, sourcing aspects, and scaling it, and of course with a thorough and careful design that is from a policy to an ownership to an accountability perspective is a key to the success of these initiatives. Otherwise, and I have to emphasize this, you'll just be opening up a system for something that doesn't have an experience, when out with an outside company investment to handle and manage. So yeah, it's just very critical. That's what I want to emphasize.
Thank you, Tamaskin. Nabil, is there a risk of privatizing rural healthcare?
Thanks, Abraham. I wish I had an AI tool where I could develop a presentation for, a 30-minute presentation about the risks of privatizing healthcare, because it's such a big question. I think there's definitely risks. I don't think there's no risks. I think on the first question we have to ask is, if we want universal healthcare, if we want, can we do it fully public? Should we do it fully public? Can we do it fully private? Should we do it fully private? I think the answer is no to both of them. I think the answer is there's somewhere in the middle that there will be a role for the private sector, just as there would be a role for private capital, because the private sector does have some advantages over the public sector in terms of competition and cost. Of course, profit is there, but the argument always for private is that waste is a lot less, waste and other, I would say, forms of leakage. So I think the key is structuring the right incentives, and certain things should and could be public delivered, and certain things could and should be privately delivered, right? And different types of care and different types of service and products. So I think it's always a hybrid solution. Now, the question is, do you want to create parallel systems between a public system and a private system? Or do you want to have, as we say, a blended finance system, a blended finance structure that enables a partnership between public and private, right? So yes, the short answer is it does increase the risks that come with privatization. I would say privatization is a certainty, partially, not full privatization, but partial privatization is a sort of almost certainty when you start to bring in private finance. But that doesn't have to be a bad thing. But I think if we go for full privatization, yes, it can be a very bad thing, and we need to manage those risks really, really carefully, and we need guardrails, and we need to be intentional about how we design the system, and where do we want to see competition and where do we not need it? Where do we just want a monopoly? And you know, questions like that vary, I would say, based on geography, based on product and service type, based on affordability, and so on. So I think yes is the answer to the question.
Thank you, Nabil. In the last 6 minutes, what I want to do is give Nabil and Tamasken and myself 2 minutes each. I will conclude in the last 2 minutes. But Nabil and Tamasken, I want to give you an option of responding to any pertinent question on the chat. You feel we should not close this session without responding. There's been so many on the chat and then on the Q&A session. Just take 2 minutes. If you don't have anything to respond to, please include your final messages for the relevance of blended finance for primary healthcare. Over to you, Tamasken, and following Nabil.
Thank you, Abrish. And first, I want to really extend my admiration for the great questions and discussion, and of course for the moderation as well, Abrish. I don't really have any questions, specific questions that I want to respond to. I believe most of them, at least the most important ones, have been raised, and of course there would be on so many other discussions, questions that could be raised, especially on something as new as this. There should be questions, and there would be questions. I just want to say that there would be follow-up discussion platforms on blended finance where people anywhere in the world would exchange ideas, answers, forward their questions, and so, which the team behind this webinar would also facilitate, like any of our other webinars. Particularly with the topic of discussion that we had, I just want to say that I think so. The thing about financing is that it's a real challenge. It's a real challenge, meaning someone has to pay for a service that you provide. So even if you're giving that service for free, someone is paying for it. If someone is not paying for it, you have to pay for it. So there's always that trade-off, and with everything that is happening and that would happen with a lot of things, with inflation and with everything, I think practical and concrete solutions at the very least needs to be tested out and see if they would be feasible and can be scaled. So I do have high hopes that this would be something that Ethiopia would test out, have started in some way, but would actually have a concrete results and learns that it would share to the other LMIC countries in the same way that it was able to share its successes on the community health or health extension program.
Thank you very much, Tamasken. Over to you, Nabil.
Thanks, Abraham and Tamasken and everybody here. Yeah, I think there's a very good discussion here. I can see a lot of questions. I've tried to answer some of them in the Q&A by typing while we're talking. But I think there's maybe just one really important thing to say. I mean, as we said, we're talking about blended finance because there's a limitation on public finance, especially in the current moment, and there's a limitation on donor finance. If there was no limitations, I don't think this would be a relevant discussion. But there is a shortfall, right? So I don't know that we have the luxury to question if blended finance. I think we have to focus on how blended finance. But what would be interesting is to talk about what can it bring other than more money? Because if we're only talking to any financier because they bring money, I think I'm a financier. That's not an interesting conversation. The finance has to add value. So let's talk about public finance and private finance. Public finance is different to private finance. Okay, public finance is something. Well, let me start with private finance. Private finance is like a mirror. It reflects back the viability of your project. It does good risk analysis. It does good credit analysis, whatever it is, and it says this is an attractive project, and the money flows. So it has a performance element in it, in that it evaluates and says this is a good investment, whether it's the delivery capacity or whatever. And it's a very good filter of making good investments from bad investments, private finance. Public finance, what the Ministry of Finance allocates to the Ministry of Health or to the county or to the region, that's not based on merit so much. And there are public finance management experts who'll say, well, it can be and all of that, and that's fine. But by and large, money that goes to regions or money that goes to ministries is more or less like a right. So it's not so much performance-based, and we talked about outcomes-based financing. So there's something, when you bring a public finance and a private finance together, I think there's some value add actually to both of them, right? Because as we said, universal healthcare is a right? But the finance should go only when that is actually delivered, right? Not for the inputs, as I said earlier. So I think blending public and private finance actually creates more than just more money. It creates a different level of accountability into a system, which I think we would all agree is a good thing. And so, yeah, I would say the big thing that we need to look at when we look for blended finance is how can this improve the incentives and the performance of our health system? And if it's not doing that, then I think what you said earlier about the risks of privatization will probably outweigh the benefits of blended finance. But if we can bring in a more incentive-based system, more outcome-based system, healthy system, competitive, maybe, how do you say, competition for resources, some of those benefits through blended finance, then I think we would see that it would not only just bring more money, for which there is a shortfall, but it would actually bring an improved system. Thank you.
Thank you very much, Nabil. Thank you very much, Tamaskan, for sharing your insights. And thank you everyone who has joined us. I think, after this session, whenever we walk, in those streets and see a mall, we start thinking, with the right incentives, this money could have been invested in primary healthcare in some rural area. So it really got us thinking. But I think today's discussion reminds us that blended finance isn't just about money. It's about partnerships, it's about impact, and it's about scaling solutions that work on the ground and really using the right incentives from the holders of the finance, from the holders of finance capital, and also the right incentives for those who deliver results on the ground. Let's take the lessons forward and think about how we can use blended finance in a smarter, fairer, more effective way to drive real change in primary healthcare. Thank you everyone for joining us, and a warm gratitude to our distinguished speakers as well. With this, we conclude today's webinar. Over to you, Baruch, for any final announcements.
Thank you, Abraham, for your excellent moderation, and I'm also very grateful for the speakers who delivered an amazing presentation. And I see it was like a very hot discussion, and we have questions that are not addressed. So I just want to invite everyone to join our committee of practice and continue the discussions here. I will put the link in the chat right now. If you haven't, signed up for the committee of practice before, please do now, and let's continue this discussions here. Yeah, thank you so much.